Hey, it's Dr. Centeno, and thanks so much for joining us this morning. Today, we've got an interesting topic. Going to go over how to navigate the maze to a CCI diagnosis and or a PICL procedure. I think there's a lot of patients who get very confused about what tests they should be doing. How do you navigate this thing, either at our clinic or elsewhere? How do you find a specialist? And it's very, very confusing for patients. It always has been, and that's because there really aren't a lot of CCI experts out there, either non-surgical or surgical. So I wanted to sort of dive into this morning, and then we'll get into Q&A as we normally do. So I'll spend maybe 5-10 minutes going through this information, and then we'll open the floor up to questions and answers. As always, if you have questions, then just go put those in the comments where you are, whether you're on Facebook or on YouTube. And I can then see those, and I'll put your question up and answer it. So again, if you're just joining us, we're getting into how to navigate the maze to a CCI diagnosis and to a PICL procedure. Going to start with about 10 minutes of that. Then we'll get into questions. If you've got questions, best to get them in earlier because sometimes I can't get through all the questions I get. And just put them in the comments wherever you are, whether you're on YouTube or on Facebook. So let's get into this concept of how to navigate the maze to a CCI diagnosis and the PICL procedure. So to get a CCI diagnosis at its most simple, you need two things. Number one is you need the right kind of imaging. And this one really confuses a lot of people. They just seem to have a hard time understanding that they can't just get a routine neck MRI and some routine x-rays and that someone would be able to see craniocervical instability on that. In addition, you got to find the right expert. And this one, even more so than imaging, really stumps a lot of people. It's hard for them to believe that they can't just go down the street and go see the local neurologist or their local spine surgeon or their local interventional pain guy or physical therapist or chiropractor, and that person will just immediately know that they've got CCI or they don't. So we're going to get into that a little bit more. So imaging, one of the hardest things for patients to understand is that while a routine MRI, and that's when you're in a tube lying face up, might show some circumstantial evidence of craniocervical instability, it's really not going to show whether or not someone has craniocervical instability or not. And again, that's a hard one for people to understand. They believe that an MRI is sort of like the Oracle of Delphi, and it has all the answers. And the reality is for craniocervical instability, it really usually doesn't. And the same goes with standard neck x-rays or CT scans. I see this all the time on social media. People throw up one or two neck x-ray images, or they'll throw up their neck MRI report and ask other patients whether or not this shows they have craniocervical instability. So realize that a routine neck MRI just isn't going to get it done for this diagnosis. Now, there are things that you can see on a routine neck MRI that might be highly suggestive of craniocervical instability, but that's the exception more than the rule. More often than not, you're going to see circumstantial evidence, but not direct evidence of craniocervical instability. Expertise. It's really hard for patients to understand that their local neurologist, PCP, spine surgeon won't generally understand CCI. Now, the good news is I've spent the last 3 or 4 years lecturing to hundreds of providers. That includes PM&R doctors, chiropractors, integrative health doctors, docs that do regen med and physical therapists on CCI, trying to educate them. What is this? What are the treatment options, etc. So the knowledge base of getting diagnosed out there through some expert is increasing. And we have localized experts that I know of that can diagnose craniocervical instability. So, for example, if you're in the Metro Virginia area, I can give you names of doctors there who generally understand craniocervical instability and will look at you as a CCI patient like this is something that needs to be diagnosed or ruled out, not like you got a big third eye in the middle of your forehead or something. So what does this process look like at Centeno-Schultz? Let's kind of walk through that a little bit. First is the overarching goal of everything we do at Centeno-Schultz is to try to make sure that if you're going to travel to our clinic, that there's a really good chance we can help you. Now, that can get frustrating at times, I think, for patients, right? Because patients sometimes are like, wow, I had to go and fill out this questionnaire online, and then I had to go upload all my imaging, and then someone had to screen it, and then I got this telemedicine appointment, etc. But all of that brain damage, if you will, is to try to make sure we can help, because there's nothing worse for me when I get on a telemedicine, or my colleagues when we get on telemedicine, and it's very clear that we don't have the information necessary to make a diagnosis. You know, that person just wasted, on my schedule, 2 months waiting for a telemedicine, and they're frustrated, and they should be. Or even worse, if someone were to travel out to our clinic and they're really not a good candidate for this stuff, we probably really can't help. So I try to avoid that with this process that I've put together. So to make this very simple, right, you get the correct imaging, which is going to be movement-based imaging, always for craniocervical instability. You then get typed into a CCI type, if you have CCI, during a telemedicine. And then eventually you'll get a hands-on exam. And that's going to provide some more information about what we need to treat and how. And then you can get treated. Now, it's even a little bit more complex than this. This is the simple version of how all this works. The more complex version, let's just start with imaging, right? At the end of the day, we have a patient who has some imaging. If they need something like a DMX, there's really two options. One is to actually get a DMX. The other is to get a local X-ray provider who will do an APOM, or open mouth AP view with lateral bending. And that can hopefully substitute for some of the things we're looking for on DMX. So either one of these things generally will suffice. Oops, let's go back here. Either one of these things generally will suffice. And then once I have those, you've got to go through pre-screening. That pre-screening is where I look to see that there's something going on there that looks like craniocervical instability. And if you still can't get that kind of imaging, there is even another option, right? If you just can't get either one of those images at all where you are, whether you're out of the country or just in a part of the US where that's not easy to get, then you can certainly go ahead and come out, and starting just the beginning of January, you'll get a DMX at our office. And at that point, you can see either Dr. Pitts or Merkel, who will be seeing you in what's called a flex slot. And that flex slot means that they'll be able to do a hands-on exam, look at all the imaging, including the DMX, and make a decision on what kind of treatment you might need. And they'll be able to treat either one. Now, in my schedule, just because I'm down to only 2 days a week in clinic right now, you really need to make sure, or I need to make sure, that you're a PICL candidate, because that's what I do with my 2 days a week. But Dr. Pitts and Dr. Merkel have more flexibility on their schedules to do a posterior if you really need a posterior, or do a PICL if that's what you need. Obviously, you can also get an upright MRI with flexion and extension. That's one possibility. You can also get just routine cervical flexion extension x-rays that can show type 3 CCI. But for the most part, most of our patients are going to need a DMX and upright MRI with flexion extension. In looking at it another way, realize that if you're a patient, I'm going to pre-screen everything that you submit. And once I pre-screen that, it's going to either be your imaging shows CCI very clearly, or it doesn't show CCI very clearly. If it shows CCI very clearly, you'll get a telemedicine slot. And if you're an PICL candidate, then you can get on my schedule. Now, if the imaging doesn't show CCI, or I think you need more imaging, we're going to get that imaging done. And you might have craniocervical syndrome, or you might have posterior instability, or you might be looking like a PICL. If you have craniocervical syndrome, i.e. not CCI, or posterior instability, then you might get advanced posterior injections on Dr. Pitt's or Dr. Merkel's schedule. So that's kind of how that works. Also, one of the things I want to make sure I discuss, because I see this all too often, is I see financially constrained patients who spend a lot of money on stuff that is unlikely to work or is unlikely to help in the diagnosis, and they have little left to proceed with what I consider a more definitive treatment. So let's go through this for a second. If you're financially constrained, and not everyone is, we have patients where this is not an issue. They go get whatever imaging they want to. And then I'm always happy to look at that information. But some of the things to avoid if you're financially constrained would be many posterior injections if you've got internal ligament problems. So for instance, I see lots of patients with CCI type 2B. They're told by certain clinics that they can do these posterior prolo injections or posterior PRP or posterior bone marrow, and that should work just fine. And sometimes they get half a dozen or a dozen of these, didn't help. They've spent $10,000 or $20,000, and they were doing treatment that really wasn't likely to help. Another thing I see are clinics offering, quote, neck vitals, which are ultrasound measurements, Doppler ultrasound measurements of the internal jugular vein. They do some intraocular pressure monitoring. The problem is we have no data that shows that any of this is linked to CCI diagnosis. So it's just not helpful. They submit this to me and I'm like, I don't know what this means. There's no standardized data that I can look at to take this information on the quote neck vitals form that they paid thousands of dollars for that will help me make a CCI diagnosis. Zero. Now, the providers that are offering that could certainly do that research, but they're not doing that research. So that's what I consider useless information that's expensive and saps patient resources. Peptides are another one. Will they help? Well, if they help, who knows? We don't know. We don't have human data on any of these peptides. So to me, they're a waste of money until we get human data. And then another one I see is CCI patients chasing down IJV compression. I'm scratching my head on that one because at the end of the day, it's pretty common to see IJV, internal jugular vein compression in CCI patients, but they're getting all these fancy tests. They're getting these fancy CBCTs or CT scans. They're getting them 3D reconstructed, and they're going down this rabbit hole when really all they need to try to do first is to treat the craniocervical instability appropriately rather than chasing that down. So in summary, there is help. There is a process to maximize the chances that we can help you. And if the maze gets too complex, consider going on the Reddit sub, r/PICL, and just pose a question. And if you need assistance in trying to figure out, should I go left or right? I spend enormous amounts of my free time answering questions here. So you can obviously pose a question on a Facebook Live or a YouTube Live. you can post a question on Reddit, and I'm happy to try to help you sort of get through that maze. So let's go to some questions now. Let's see here. I want to get us back to a different format. Okay, so we'll go to some questions here. I'm going to start from the top. Zach, is the BMA process standardized at the Cayman Clinic, i.e., would you expect the same yield regardless of the doctor there? Yeah, to work at the Cayman Clinic, Zach, you have to actually have gone through training on how to do a proper bone marrow aspirate. So yes, that's very much standardized at the Cayman Clinic. Now realize the Cayman Clinic is not for CCI patients. It would be for patients who have other spinal problems or peripheral joint issues, but Cayman would not be a good match for CCI patients. Kathy, can CCI cause fluid in neck to build up and move into your head? Kathy, I think what you're describing might be one of two mechanisms. The first mechanism would be that if there's outflow decrease at the foramen magnum, which is the big hole at the base of the skull, either in the back of that big hole or foramen magnum due to low-hanging cerebellar tonsils, or in the front where the dens pushes too close to the brainstem and upper spinal cord, you can see decreased movement through that area of cerebrospinal fluid. Another mechanism might be intermittent pinching off of the internal jugular vein flow that can happen in craniocervical instability. So yes, that can occur. Now, be careful here because that's posited for the reason why, for example, CCI patients have headaches, when in fact, it's not the dominant reason that CCI patients have headaches. Those headaches come from many other things outside of this. Julie, hi, Dr. C. What's your opinion on living silica as a booster for collagen supplement for ligaments? I don't have any opinion on living silica at this point. I would need to see the research on living silica. That's a new one on me, Julie, so no real concept of it there. Hey, do me a favor. If you're watching now, give me a like, subscribe, share, simply because that's how people find this information and that's how you pay it forward to the CCI community. If you're with me here on a Sunday morning getting your questions answered, for every one of you, there's 10 or 20 CCI patients out there who aren't getting their questions answered, who don't know this exists. And the way you help them find it is to do that like, share, subscribe. Finnegan, can peptides possibly help CCI before PICL? If so, which ones? No, Finnegan, we don't have any data at all that shows that peptides do anything in CCI. We don't even have any human data on the peptides that are being sold. And all the peptides that are being sold online are illegal drug products, meaning that they're not FDA approved. FDA has stated that they shouldn't be sold and has put out multiple warning letters. So they're not FDA regulated. I don't even know that you're buying what it is it says on the vial. So no, not a big fan of peptides. I don't think we have any human data at all that shows that they do anything in humans. In addition to that, we certainly don't have any data on CCI or even, case series data. And it's unknown whether or not you're actually getting what it says on the bottle because there's no FDA regulation of peptides whatsoever. Cassian, is there a difference in quality between plate lysate from freeze-thaw versus ultrasound lysing? Cassian, the quality of a platelet lysate can be thought to be directly related to the growth factor content. So freeze-thaw can break open some of the platelets. Just so that others understand this, a platelet lysate is where we take the growth factors out of platelets and PRP, and then we go ahead and inject those growth factors in serum. So you can make that via freeze thaw, and depending on the temperature and other factors, you can get most of the growth factors out. Ultrasound will lyse some more, so you can get a higher growth factor content with ultrasound. And there are 3 or 4 other tricks to get the growth factor content as high as possible, not just those 2. Kathy, any doctors in San Antonio area that could diagnose CCI? I don't know any doctors in the San Antonio area who I know can diagnose CCI. There are other doctors out there in Texas, but I don't know anyone in the San Antonio vicinity. Walk-in beauty. I had an MRI last week, and I go to appointment Tuesday. Feels like the cervical bones are locking up in my skull at times. What is your opinion? Not sure I can form an opinion from the little tiny bit of information I have here. I can tell you that a routine neck MRI is not going to show CCI. It's probably not going to show why your cervical bones at your skull feel like they're locking up. So regrettably, we're not going to get that information from a routine neck MRI 9 times out of 10. Dr. Centeno was recently diagnosed with CCI after a DMX. Symptoms severe. Neurosurgeon is requiring a CT scan with neck turned left and then turned right to show facets. Yeah, so that, listen, at the end of the day, a rotational neck CT, which is what you're describing. So you go ahead and turn the head to the right, do a CT scan, turn your head to the left, do a CT scan, isn't really an accurate way to diagnose craniocervical instability. It's a very, very low yield, high risk way because it's exposing the patient to a lot of radiation. So if your neurosurgeon really isn't willing to accept what's on the DMX, then I'd probably find another neurosurgeon, meaning most of the neurosurgeons that do a lot of this work will have no issue looking at a DMX and saying, yeah, that's normal or that's abnormal. And rotational CT is not a great way to diagnose craniocervical instability. It's very, very low yield for the radiation exposure, which is very high. Casein, does plate lysate have to be administered via hydro dissection? If not, how else? Plate lysate is used in a lot of different places, casein. That can be, for example, for hydro dissection of nerves. It's also used, for example, to supplement other things. So, for instance, we supplement our bone marrow construct with plate lysate and PRP because both of those can help stem cells grow in culture and in vivo. And it can be used for other applications as well. So it's not just nerve hydrodissection. Lena, could you please discuss alternatives if C-spine kyphosis cannot be corrected by curve restoration rehab? Lena, there really isn't one, although it depends on what we're trying to accomplish. If what we're trying to accomplish is to get the person out of pain and improve their function, there are a lot of different ways to do that. If what you mean is that the goal is to try to get rid of kyphosis once the bones have changed shape, that's not possible. And this is an important lesson, right? If you have kyphosis in this forward head position, because like a lot of people, you do this all day looking at your phone, you got to get on top of that early rather than later, because if you don't get on top of that, the bones will change shape and there'll be no practical way to get rid of that kyphosis. Tanya, dear Dr. Centeno, I now have a telemed appointment with you at the end of January. I'm so glad I finally got it. A week before, I was supposed to start here in Germany with prolotherapy, but I'm so unsure because we don't know yet which type of CCI or maybe even type of CCI I really have. The MRI says insufficiency of the alar ligaments due to the work accident where it happened. The authorities, unfortunately, somewhat in our necks What would you advise me? Start prolotherapy? Yeah, Tanya. So the first thing we've got to get to is what kind of craniocervical instability do you have, right? That will determine what kind of treatment you need. So at the end of the day, we really shouldn't try to start treatment without knowing that. Now, regrettably, an MRI is not a great way to diagnose alar ligament problems. You would have to have a movement-based image. That could be an MRI, a DMX, etc. But a static MRI is really not going to be an accurate way to diagnose whether or not the alar ligaments are having issues. But let's say that's right. Let's say that you do have alar ligament issues, then prolotherapy posteriorly is very unlikely to help, which is, again, the reason why you have to determine a CCI type, because treatment flows from there. Lena, RE above questions, so can better manage progression of C-spine degeneration symptoms. Yeah, Lena, I think I answered that previously in more detail. Matt, great to hear from you, Matt. I had a great Christmas. Had my first great Christmas in 4 years. Reason was because I had 2 PICLs this year. Thanks. When considering a third PICL, should this be done as a combo of new scans to see reduced measurements and symptoms? How do you know when you've maximized the PICL and the rest is down to rehab? Yeah, Matt, I mean, part of it can certainly be symptoms and function and how much you're responding per PICL. We can always do things like repeat the movement-based imaging. Most common to repeat would be the DMX to see where things are. So either way is fine. Sometimes either way, it's going to turn into a judgment call as to whether or not the ongoing symptoms and problems really look more like that they're instability related, or whether it looks like it's more just you've got to get the muscles stronger. But I'm so glad to hear that you had a great Christmas because of the 2 PICLs. Merry Christmas. I'm booked for back work here in Phoenix. My second treatment, hope successful, is 2017. Gotcha. Thanks, Darlene. Do you need to separate out the platelet membrane fragments after lysing? You don't have to, but that's generally how it's done. The reason to take those out would be that they could be pro-inflammatory, and platelet lysate is supposed to be anti-inflammatory from the get-go. And it's the big difference between platelet lysate and PRP. PRP tends to be more pro-inflammatory. Platelet lysate tends to be more anti-inflammatory. Vera, good morning, Dr. Centeno. Can rotational CCI types 1D and 2B be differentiated through symptoms? Not so much, other than it is true that we see patients who come in and say that when they rotate their head, that's when their symptoms happen. So yes and no. The concern there might be that there could be other CCI types that are also sensitive to triggering a person's symptoms with rotation. But I do agree with you that if you've got rotational type problems or triggers, then we're going to be thinking the C1, C2 rotational problem of a 2B, or could possibly be a 0-1 rotational problem of a 1D. Everybody, no matter where you are, give me a like, share, subscribe. That's how people find this content. Because at the end of the day, if you're sitting here with me getting your questions answered on a Sunday morning during my free time, there's 20 or 30 CCI patients out there who don't even know this exists. And the way you pay it forward in the CCI community is to let them know this exists by liking, share, subscribing where you are. Vera, has the clinic considered different pricing for people that are able versus unable to work? Vera, we have established the pro bono CCI program, and we now have pro bono CCI patients scheduled, I think, out through February. We'll be working on the March and April slots here soon. So that's how we've tried to address that issue. If you're having difficulty, then that's one thing to consider. But no, we don't have sort of sliding scale. We've tried to address that by doing the pro bono program where the patient pays nothing for their PICL procedure, assuming that, number one, they're a great candidate, and number two, we're getting sort of a native CCI patient that's never been treated before. Plan to get, I don't know what that means as far as a question, so I'm going to skip that one. Let's see here. I think it's Dominique. Hello. If the authorities are putting too much pressure on that everything here in Germany must first be exhausted, would it stand in the way of treatment with you if my wife had done prolo before? No, a good number of patients that we see have done prolotherapy before, so it doesn't really change much for my treatment. So if the government is stating that you have to exhaust everything that's available in Germany, and that would include prolotherapy, then give it a shot. Just realize, again, what I hate to see from patients is when they get into that financial hole where they've paid for a bunch of prolotherapy that probably wasn't going to work, and then they don't really have any finances left to pursue a more definitive treatment. Big Buck Hunter, significance of disc protrusion C4-5, facing the thecal sac without stenosis, brain fog, dizziness, neck, pain, diarrhea, inappropriate sinus tachycardia, disc bulges at C5 through 7, C3, 4. Yeah, so what you're describing is probably not the cause of those symptoms. So again, this is getting back to that same concept we talked about before, right? A routine neck MRI, regrettably, is probably not going to show you whether or not you have craniocervical instability. It's going to be relatively invisible. Now, there might be some circumstantial evidence that we can find or an expert can find on that, but not the routine reading radiologist that might say, yeah, this person could have craniocervical instability. But what you're describing are the kinds of things that are commonly seen on a neck MRI. And regrettably, these aren't the kinds of things that cause the symptoms that you're describing, which are more consistent with craniocervical instability. So you're going to need movement-based imaging to get to that point of saying, yes, you've got craniocervical instability or you don't. A routine neck MRI is going to be fairly useless in trying to determine whether or not someone has craniocervical instability. What imaging to get in Finland where DMX scanning isn't available? Yeah, so I've got, if you just go to the YouTube channel, my YouTube channel, what you're going to find is there's a video on there that walks a technician through how to do a DMX-like image using routine x-rays. So I would highly advise that you go and download that, take it to a local imaging center, try to get them to do that. So you can get a DMX-like image at a routine neck x-ray place as long as they follow those instructions. Walk in beauty, and my cervical spine is pinching my spinal fluid and my spinal cord is flat. Yeah, so I would need to know more than that. So that's just a little tiny bit of information to comment on much of anything. Your cervical spine is pinching the spinal fluid where? In the front of the cord, in the back of the cord. How do you know this? Have you had a CSF flow study done? Etc. So those are all things I would need to know to try to assist you in any way. Now the question, can CCI be inactive for years due to spine compensation? Sure, we certainly see this in a lot of patients where they may have gotten a traumatic injury many years ago, and that traumatic injury caused some instability, but they were able to compensate. Let's say they were younger. And as they become older or something else happens, then the CCI starts to become more symptomatic. So yes, that's something we definitely see. If you're watching now, do me a favor. If you haven't already, give me a like, share, comment, subscribe. That's how people find this stuff. And we want as many CCI patients in the CCI community able to find this information so that they can all log on a Sunday morning and get their questions asked. Finnegan, I have a predictable flare every day between 5 and 7 p.m. What mechanisms could explain this evening spike and interventions can break the pattern? Yeah, I don't know what's wrong with you, Finnegan, so that's impossible to answer, meaning that, again, remember that CCI diagnosis is very specific. A type 1A, a type 1C, a type 1D, a type 2A, a type 2B, a type 3A, a type 3B. All of that would be important, but what I can say in general is for many patients, they can get sort of cumulative trauma throughout the day, and then that can build up so that their symptoms are worse towards the end of the day. Julie, my doc said I have degenerative cervical myelopathy, the spinal fluid not draining properly because C3 and C5 is pressing into the spine. Also, my vertebral artery is pulsing against the medulla. He said that's dangerous, can cause loss of function, requires a top surgeon. Is there something you can do for these issues? Yeah, Julie, I'd have to look at all of your information in context. That would include all of your imaging, your symptoms, etc., to even know whether or not the C3 and C5 has anything to do with your symptoms or whether or not your vertebral artery has anything to do with your symptoms. So really can't answer in this kind of online context without knowing a lot more information. Big Buck Hunter, how to approach a neurosurgeon about CCI, several disc issues, but I suspect CCI. Yeah, as I was saying before, this is a very important question, and it gets to really why I'm talking about this topic this morning. And that is, at the end of the day, the average neurosurgeon isn't going to really have a good sense of this kind of craniocervical instability. They certainly know that craniocervical instability can occur in a massive trauma situation coming from the ER where someone's head is basically falling off and they need emergent surgery or they're going to die. Outside of that, the average neurosurgeon isn't going to understand this kind of elective craniocervical instability and the disability it can cause. So if you're looking for a neurosurgeon to understand this, you don't have that many options. You've got Dr. Bolognese in the New York metro area. You've got Dr. Patel in South Carolina. You've got Dr. Henderson in Maryland, Dr. Frank in Panama City, Florida. You've got Dr. Gillette and Oliver in Barcelona. And that's it when it comes to neurosurgeons who will immediately recognize what's going on and what needs to be done. Now, there may be some others out there on the margins who might be more understanding of what's happening. But that's the list where I know that if you walk into those offices and you've got CCI, they're going to understand what it is and they're going to immediately know what to do. Kathy, should I avoid any kind of cervical rehab if I do have CCI? You know, Kathy, yes and no. Active rehab can make CCI patients demonstrably and predictably worse. Having said that, things like postural rehab can be very helpful as long as you have a physical therapist that understands how to work with CCI patients, which is why we recommend Todd Ball. Todd has worked with many of our patients through the years and has adopted and adapted a program that can be easily fit to a CCI patient to meet them where they are functionally. So again, it really depends on the type of rehab program. Vero, how are cervical annular, let me start that one over again. Vero, how are cervical annular tears treated with injections? Do they heal or what's the outcome? Yeah, Vero, annular tears can be treated with a direct injection of the disc, usually with PRP, sometimes with bone marrow concentrate, sometimes with other things. But it's a risk-benefit thing, right? We have to be convinced that the tear is causing symptoms because injecting the disc, whether it's in the neck or in the low back, adds certain risks. So you've got to be clear that you're not going to hurt that person by trying to treat something that is seen on imaging but doesn't cause symptoms. And that's a critical issue, right? If something is seen on imaging, it doesn't mean it's causing symptoms. It may be completely asymptomatic. BM Home Services, wife had her pre-screen reviewed by, would have been me last week, and a DMX was recommended. Her upright flexion extension flared her and admitted her to the hospital from neck movement. Do you have any alternatives? I don't. You need movement-based imaging, so not quite sure what to tell you there, other than she could go into a flexible slot at CSC, so that would mean that she would get a DMX done at CSC, and then from there, she could go to a hands-on exam. That would be Dr. Pitts or Merkel, not on my schedule. And from there, it can be determined whether or not she needs a PICL or just upper cervical injections and advanced posterior treatment. At least that way, if she has a flare, then she's going to get treated. Now, if something like an upright MRI put her in the hospital, then that's not a good sign. She may not be appropriate for outpatient care at all, which means that her only option would be surgery. And that's an important thing to realize, and that is that outpatient care involving something like a PICL is not for everybody. And there are patients who are so fragile or have other medical conditions or other problems where an outpatient procedure isn't a good fit. They need to be inpatient to be treated, and that would only be surgery. What's a DMX? DMX means digital motion X-ray. It's really just video fluoroscopy. What that means is that it's a live movement-based image of the neck bones. So you can see the neck bones like you do on an X-ray, but you can see them move in various positions. So in the case of craniocervical instability, we're looking for too much movement in the upper neck bones. Casein, are there certain symptoms from CCI that make you certain a certain type of CCI type is present rather than other CCI types? Not really, Casein. There are certainly things that suggest certain types. I talked about one. For example, rotation flaring the person suggests a 2B, or if someone has significant problems with nodding looking up, or anti-nodding, I guess that would be, or 0-1 extension, then we might be thinking about a 1C, but those are just generalizations rather than specific diagnoses. Thank you, Dr. Centeno, always so helpful. Happy to help. Finnegan, for my last question, I've been diagnosed with type 1A, 2B, and 3A CCI. Let's see, Finnegan, I got to go back a little bit to see what we were talking about. Yeah, Finnegan, doesn't really change the answer to the question, though, meaning if we're talking about a specific patient where we've tried to solve that issue of why is this happening, that's different than in a social media format like this. Kathy, should muscle relaxers be avoided with craniocervical instability or CCI? Most CCI patients, if they have medications that relax their muscles, that could be muscle relaxers, alcohol, or, for example, getting a Botox injection to relax the muscles, they tend to flare up. So at the end of the day, most CCI patients would not respond that well to muscle relaxers. Now, a lot of that's going to depend on how much muscle relaxation you actually get. If you get more, then they're probably going to flare up. If you dial it down just a little bit, then they might feel better. Haley, when you see a patient with significant upper cervical misalignments and fixed rotation, does that place them in a camp of patients that will likely require multiple PICLs in order to see notable functional improvement? Or have you seen patients respond and maintain better alignment with just 1 or 2 PICLs combined with AO NUCA treatment? Yeah, Haley, the only thing that is so far predictive of needing fewer PICLs would be if we get someone from a traumatic injury within that first 12 to 18 months of symptom onset after the trauma. Outside of that, I quote the same for everyone, which is going to be 2 to 4 treatments. Alex, is there a time after PICL we should expect to start holding alignment longer? Almost 7 weeks post-PICL, haven't held longer yet. Most relief comes from being in alignment. Yeah, so that's going to really be, Alex, more into the ligament tightening phase. And that's going to be a bit later, kind of in that 3 to 4 month mark. And you may not hold longer after just one. You may need more than that to do that. But that's generally when that happens for most people. Greg, you mentioned things, imaging may or may not be the cause of symptoms. How do you determine and rule out if there are or are not a piece of the puzzle? Yeah, so Greg, this is a great question, and that's really the art of medicine, certainly in this area. So for example, is a disc bulge causing someone's symptoms? Well, let's take a specific thing. Let's say we've got a C5-6 disc bulge. We expect that to irritate the C6 nerve root. We then go on to physical exam and see if there are signs on physical exam of the C6 nerve root having problems. So that would be looking at the C6 dermatome in the thumb, for example, or looking at the pain pattern for C6, which can be into the upper back, or looking at whether or not when loading that area or doing things that would irritate the nerve, someone gets numbness or tingling into their thumb, or whether or not the C6 innervated muscles are having problems. And that's how we go about that, right? It's a combination of history and physical exam to try to put the pieces of the puzzle together. Alex, I got to go back to what was asked before. Still looking here, Alex, trying to find the last post. Yeah, Alex, not finding the last. Oh, wait, here it is. Gotcha. This is the last post here. Okay, type 2B. Yeah, so Alex, again, I don't know when you would start holding specifically. It's going to tend to be more in that 3 to 4 month time frame. In addition to that, if you've got 8 millimeter overhangs, then my sense would be you might need more than 1 PICL to get there. Alex, I've read that PRP heals in 4 weeks. I had C0 through C4 facet PRP with PICL. If my dizziness was coming from the facets, and at almost 7 weeks, dizziness hasn't gone down much yet. Is that a bad sign, or does it mean they need more treatment? Yeah, Alex, it depends on what's causing the dizziness. Is the dizziness coming from just the joints, or is it coming from the movement causing too much irritation in the joints? So for example, if it's the first, then you may get relief fairly quickly within a couple of weeks of a PRP shot. If it's the latter, then you're not going to really get relief until the movement starts going down. James, are you familiar with electroacupuncture? Yes, James, very familiar with electroacupuncture. At the end of the day, I think can be helpful for various types of issues. I don't think it's going to be all that helpful, though, for craniocervical instability. Okay, guys, we're starting to come to the end of the questions. That's an amazing feat, but I suspect it has to do with the holidays and people out, obviously, with family. So if you've got other questions, I've got another 5 or 10 minutes. Throw those into the comments where you are, and I'll be happy to answer those. So if you just type a question into the comment on YouTube or comments on Facebook, I'll see it here and then can answer that question. just to review what we covered earlier, and that is, at the end of the day, navigating the maze of getting to a diagnosis can be very difficult to do for patients. What we try to do at Centeno-Schultz is to try to focus on, if we're going to bring you out, we want to make sure we can help. Or if we're going to do a telemedicine, we want to make sure that we have all the information needed to get to some sort of conclusion for you. So, and then we were just talking about some of the tricks of the trade, if you will, or things to avoid in getting that CCI diagnosis. James, why would electroacupuncture not work for CCI? Wouldn't work for CCI because CCI is a problem related to too much movement in the upper cervical spine. And electroacupuncture is not going to really move the needle there, no, pardon the pun. So we're not going to see a change in craniocervical instability. In addition, that can involve joint damage. Electroacupuncture isn't going to change that. That can also involve symptoms being caused by irritated nerves. That one you could get some help with electroacupuncture, but then the nerve is just going to get pissed off or irritated again. Greg, can CCI cause burning in between the shoulder blades? Most of our CCI patients have burning between their shoulder blades due to other factors than CCI, but we do have CCI patients that just have, quote, upper back pain, and that may be generating solely from the CCI. Alex, do you still recommend the laser exercises versus harder rehab methods when you're highly functional, work full time, exercise lightly, etc.? I think, Alex, a good place to start is the laser exercises. If you can progress quickly through those, then you might want to consider getting with Todd Ball, who can do a postural program. If you think that's too easy, then IPA physical therapy would be a good next step from there. Continuing on the upper back pain issue for Greg and burning down spine. Sorry, I got cut off. Really same answer there, Greg. Alex, how important is curve correction in overall healing? Pretty important, but realize that most patients can't do curve correction out of the gate. So they'll need their CCI or CCS treated to get to that point. But just realize that the lack of curve can put too much pressure on the upper cervical spine. And that's the reason why this would be a good thing to address at some point in your healing journey. Lena, does Todd Ball do virtual appointments? He does do virtual appointments. So that's a good one to consider. Carol Yates, been advanced by Sherry Scott. I have found that sleeping with no pillow helps. Is that okay? Sure, that should be fine. Dominique, 1,000 thanks for everything. Have a good start to the new year and have a nice Sunday. Thank you so much, Dominique. Julie, thanks, Dr. C. Happy New Year. Thank you, Julie. Greg, thank you for your time. Greatly appreciated. Happy holidays to you and your family. Thank you, Greg. Amber, have HEDS, POTS, chronic migraines, MCAS, have all the CCI symptoms, but never evaluated for CCI. Migraine, Botox, and neck and shoulders helps the pain, but not the other symptoms at all. Consider CCI. Sure, Amber, I can't give you medical advice, but I can tell you that if you've got CCI type symptoms that and HEDS, that getting it ruled in or ruled out would be a good next step. Haley, quick feedback. The entire team at CCI Clinic is so professional and works together like a well-oiled machine. Seems everyone knows their specific role very well, and each person I saw the day of the procedure did nothing but build my confidence. That was one of the best hands. Kudos to your entire team and leadership influencing the team. Well, thank you so much, Haley. Yeah, we do have a great team, and they do work well together. I hear this all the time from patients, that they make patients feel at home, they make patients feel comfortable, and that, especially for this PICL procedure, this has become so well oiled at this point. I think that's a good way to put it, that patients can go from step 1 to step 2 to step 3 to step 4 very smoothly. And everyone knows the answers to questions, or if they can't answer questions, they can get someone who can. So thank you so much for bringing that up. I know the staff loves to hear that feedback, and I get that feedback all the time from patients. So thank you. Amber, thanks for answering and all your great info. Thank you, Amber. Okay, guys, I'm going to start wrapping it up here. I want to thank everyone for spending a Sunday morning with me, getting their questions answered. Great questions. It's always great to get questions answered, because that's how many of us learn, is through getting our questions answered by others. And many times you can see that you've got the same question. So Happy New Year out there. And I will be here this next Sunday answering more questions, and hopefully we'll have another topic. So thanks so much, and have a great week.